Thanks so much, Paige. I appreciate that. I'm Debra Stevens, and it's my honor today to introduce my co-presenter. Nick Stavros is the CEO of Community Medical Services, where he's worked for the past 11 years. And prior to CMS, Nick served as a captain in the U.S. Army. After an 8-year career, he went on to earn his MBA from UCLA. And Nick currently serves on numerous national and local boards and associations as part of his larger effort toward educating communities on the need to treat substance use disorders from a place of compassion while advocating on behalf of effective modalities of substance use disorder treatment. Community Medical Services offers opioid treatment services through 75 centers across 13 states, and their vision is to eliminate the consequences in our communities. My name is Debra Stevens. I spent the last 17 years of my career in healthcare marketing, currently serving as Senior Vice President of Community Relations and Communications and Donor Relations for Honor Health Foundation. I'm very grateful that Valley Leadership has given me the platform to use my skills and my passion to fight against the opioid crisis. You're going to hear both personal and professional stories today, and I get the pleasure of starting us off. So there's a vicious stigma cycle, right? And as you can see, 78% of Americans believe that people who are addicted to prescription opioids are themselves to blame for the problem. In fact, the vast majority of people believe that those addicted to prescription opioids lack self-discipline. Here's why, well, there's other stats here too, but the good news, I guess, is the growing number of survey respondents in this research said that they would be willing to work closely on the job with a person with drug addiction. So that's low, but it's actually higher than I thought it might be. And about 30% of patients were prescribed their opioids for chronic pain that misuse them. So a few stats there just to get you thinking about it. But I want to tell you a little bit about why reducing this type of stigma is so important to me. In 2013, when I discovered my son was misusing opioids and had become dependent, I was among these percentages. My own perspective was really clouded by stigma. Though I didn't know it at that time, our son was 21, our journey actually had started 5 years earlier. My son, at the age of 16, had a really bad car accident with several of his basketball teammates in the vehicle with him. He was at fault. He was thrown from the vehicle. Thankfully, his passengers, several of the basketball team members, all had seatbelts on, and they were not seriously injured. My son had a broken leg and concussion and other, bruises and banged up and scrapes and that sort of thing. But he lost out on the thing that was most important to him, and that was basketball. He was not able to play because of his broken leg, but also for disciplinary reasons for the rest of the season. Parents of the other kids reacted like many parents would. Stay away from that kid, he's trouble. And my son became very depressed, and I did not know it. He began using the opioids even when his physical pain was gone, because he was self-medicating his emotional pain of all the loss and the shaming that he experienced after this accident or crash. So for about 5 years, he took ever-increasing numbers of pills. He eventually began injecting drugs. He sold everything we had ever given him that was of any value whatsoever to pay for his addiction habit. He began stealing when his dollars ran out from us, from others, to feed this increasing need to assuage the guilt and the pain and the shame that he felt. After high school, he had moved out, so all this was happening unbeknownst to us. We just didn't see it happening. When he would visit, he would be pretty much the same as always, our happy young man, living on his own, working, going to college. And then he started coming over, and he'd be over 5 minutes, and then he'd be asleep on the couch. And I think, oh my goodness, that kid is working so hard. And yet it was, he was coming down from his drugs. And as soon as dinner was done, he didn't even want to stay for dessert. He had to leave. I thought, oh gosh, he's so responsible. He's going home to get things ready for his next day, but he was going to take his next hit. We didn't know any of this. We were so protected and sheltered. We just didn't know. And a very brave friend who had her suspicions told my husband. And we confronted him, our son, and he admitted it. And we were devastated and had no idea how to proceed. Now I want to tell you how stigma plays into this. This crisis was happening in our family, and I didn't tell a soul. We kept it to ourselves. We didn't reach out for help, didn't talk to my employer, didn't tell anybody because I was embarrassed and ashamed. I said, my child shouldn't be doing this. So I was both a victim of stigma, but also a perpetuator of stigma, I will say. I have to admit that now. My lack of knowledge about OUD at the time was very evident in how I reacted at each turn in our family's addiction journey. I was really, really angry at my son. That was my primary emotion, I guess. I blamed him for ruining his life and really hurting ours as well. My husband and I really disagreed about how to support Kyle's recovery. And we didn't understand how to balance support without enabling him. It felt like all or nothing to me. I didn't know at the time that consistent drug use rewires your brain. That's what opioid use disorder is. OUD is that change that happens in your brain, in your body, and it is a disease that requires treatment. While drug use does include an element of personal choice at the beginning, it's also really important to understand, as I had to learn, that the external factors outside of an individual's direct control contribute to their addiction. So, for example, an injury like Kyle's leading to medically recommended prescription opioid use that progresses into an opioid addiction. Some people may use drugs to help cope with their stress or trauma or to help with mental health issues. Many develop opioid use disorder after misusing opioids that they are actually prescribed by doctors. In any case, using drugs over time just makes it easier to become addicted and to end up with opioid use disorder. You know, people hide their addiction. I hid my adjacency to addiction, but for those brave people who've been open, their lived experiences and their stories of recovery provide hope to people like me who need to learn how to help our loved ones find treatment and to live in recovery. And they provide hope and improve the chance that those who want to achieve their own recovery see that in their future. So what was my turning point? In my professional life, I hired a young man who I really liked. He was a good, strong worker, very creative, a wonderful writer. And he and I had a very honest conversation one day, and he admitted to me that he had been addicted previously and was living in recovery. And I was shocked. I was shocked because I liked him so much, and how, you know, it was just a different experience for me to feel positively about it. Not too long after that, I had lunch with a dear friend who confessed to me that he was in recovery. And then John Koch, if you heard him tell his story yesterday, he and I met through Valley Leadership and had breakfast one day, and he shared his powerful story in session 1 yesterday. We met over breakfast, and I just really admired him, admired his strength and resiliency. And ding, 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 the light bulb went off for me. If I can admire these people, couldn't I admire my own son and be more supportive and less punitive through his journey? I realized that his mistake occurred when he was 16 years old. And I thought back to the dumb things I did at 16, and that I wouldn't want my entire life to be defined by those mistakes. And I learned that his brain had been rewired, and he now had a disease that was forcing behavior that he didn't really want to stay in either. The bright side of my son's addiction journey is that whenever we approached him believing that he was probably using or using again, he always wanted to get help. Sometimes people with OUD can't see themselves doing anything else. They can't see themselves getting beyond. But our son wanted to, and so he's been to treatment multiple times, which is very typical. But I opened myself up at that to help him get treatment and to learn more, to educate myself about this disease and the right way to support someone with opioid use disorder and to help reduce stigma. So that's been my journey. So I want to tell you just a few more things about treatment settings and how that weaves into our story. And then I'm going to toss it over to Nick. So if you come across someone you know and love, maybe someone you work with, what might happen is that they overdose, right? So at some point that may happen, or they need emergency treatment. So emergency setting is one place where they can get treatment, but that treatment is just to stabilize them. So I would encourage you to call 911. I would also encourage you to learn how to administer Narcan or naloxone, and have some and keep it on hand so that you're able to step in and help that person. There are times either from the emergency department or as recommended by a physician that a person with OUD will go into inpatient treatment. This could be a hospital, but also might be a center that specializes in this sort of treatment. Also, there are throughout the country certified community behavioral health clinics. They support patients or members with mental health and mental, behavioral, and addiction crises, and help them coordinate the care. That's one of the really frustrating things for people, is to coordinate care and all the different treatments that you need, and what is the best one and which one can I afford. And they are required to take any patient, whether they can afford the treatment or not. So that's a nice thing to look at if cost is an issue. Residential treatment. So my son did go to residential treatment at first. He went to California, and at the time that this all occurred, we were told there wasn't great treatment opportunities in Arizona. Whether that's true or not, I don't know. It just happened to be what we were told. We didn't know any better. So we sent him to Southern California, where the treatment centers are more mature, I'd say, or were at the time. And he was in a residential setting. We were told maybe 30 days, but it ended up being 90, also not atypical. And in that time frame when he was in residential treatment, he was getting intensive outpatient treatment, IOP. So that is therapy sessions several times a day. It could incorporate medically assisted treatment, MAT, which Nick will tell you a little bit more about. But the key word is intensive here, right? It's not just a, go to therapy once or twice a week. It's every day, sometimes 3-4 hours. But what they're trying to do is get to the root cause of the emotional or the behavioral issues that cause the drug, them to turn to drugs in the first place. There are also a lot of outpatient options, and I think Nick will talk a lot about that, because somebody might want to continue working. They might not have the ability to leave their job for 90 days of treatment, right? So, or may not be able to afford intensive outpatients. So there are outpatient options. And there's a growing number of telehealth options, especially for behavioral health, but that would also include OUD. And then finally, another way to get treatment is incarceration. So sometimes in that setting, someone will get the treatment they need, but quite often they don't get any treatment, and then they withdraw, and that can be very dangerous, a rapid withdrawal. So better to do withdrawal under the supervision of a physician. So, excuse me, we went with residential and intensive outpatient, and then Kyle was doing much better, came home, went back to his job. We were very fortunate. He was very fortunate that his employer allowed him to take a medical leave and then to come back to his position. And then in future, when he had a relapse a little bit further down the road, he chose an outpatient option, along with 12-step meetings, and that helped him as well. So I just wanted you to know that there's lots of different settings where people can get help, and the one that's right for any individual can vary greatly. So I'm going to turn it over to Nick now, and he's going to share some additional information.
Thanks, Deborah. Can you guys hear me okay?
Yeah.
And thanks for sharing your story, Deb. I actually developed some questions as you were talking, but I'll save them to the Q&A at the end. But very cool story, and thanks for just opening up to us. So I'm gonna talk a lot about what's called medication-assisted treatment. I think you guys have probably heard of it through some of the prior sessions. And I'm going to talk about methadone treatment in particular. It's not because I have a preference towards any specific modality of treatment. We, as a treatment agency, we just follow the science and the research, and what the science, we've built our business, basically our business model around what actually works, what has positive outcomes. And so this slide is, I know it's complicated, but if you could just stare at this for a second. I love this visualization because this is what's called an evidence map. And an evidence map is actually, it highlights like a density of multiple studies and then looks at the strength of evidence supporting a treatment's effect. So on the top, on the x-axis, those are different types of disorders or diseases, and on the y-axis, going down on the left, those are treatment interventions, types of treatment. And what this evidence map is actually looking at is the volume of treatment studies and meta-analyses, which meta-analyses are studies that study lots of studies, so they're typically more accurate, and then it's actually showing where the evidence is strong in favor of a certain type of treatment for a certain type of disorder. So you can't see it here, but I tried to add some arrows at the last second, but it was too late. But if you look right in the middle, a little to the left of the middle of the top, it says heroin opioid use. And then when you go down, follow this line all the way down, you'll see the size showing the volume of studies. Yeah, thanks. The volume of studies and the supportive evidence behind those studies as a treatment modality. So that first big circle you see, that's buprenorphine. Yep, if you reference it to the left, that's buprenorphine. The one below it that's even bigger is methadone. Then when you go down to the green, that's naltrexone. On the bottom half, it's non-pharmacological interventions, so 12-step cognitive behavioral therapy, contingency management, motivational interviewing, structured counseling. I'm just highlighting the big ones there. And what this is telling us is that the evidence is very, very clear. Methadone and buprenorphine are the most efficacious modalities of treatment for opioid use disorder. And I'm gonna talk a lot about that on the next couple slides. And again, I'm not trying to sell a product here. We specialize in doing methadone and buprenorphine treatment, and so we find ourselves talking about that a lot because actually the only types of programs in the country that can do methadone for the treatment of addiction are opioid treatment programs, and so that's what our clinics are licensed as. So we're able to do that. So we find ourselves talking about this a lot, but I'd love to run through a lot of the evidence over the next couple slides. And so right here, you see, if you just read that top sentence there, okay, it's 5 meta-analyses, so huge study sample size, 52 studies, over 12,000 people with opioid use disorder, comparing different modalities of treatment. So comparing methadone maintenance to detoxification, which is typically, it could be like 5 to 15 days of detox accompanied by medication, no treatment at all, different dosages of methadone, buprenorphine maintenance, heroin maintenance, which is legal in a lot of countries, LAM, which is a slow-acting form of methadone, and the study showed that methadone maintenance was more effective than any other study. And then there's some more. I mean, if you want to search like on Google Scholar for studies on methadone treatment, it's very clear that it's the most studied and efficacious modality of treatment for any addiction that we've ever faced as a species. And so lots of studies out there. And the disconcerting thing about all of this is most people with an opioid use disorder, the research is all over the place, but it typically says that about like 60 to 90% of people are not getting medication-assisted treatment that need it. So people with an opioid use disorder, first of all, the vast majority of people who have an addiction don't seek treatment or don't acknowledge a need for treatment. But a lot of times when they do, they're still not getting the most efficacious modality of treatment. And so, Debra, to your story, a lot of times there's a lot of lack of just understanding in our society about treatment options and the most efficacious modalities of treatment. And a lot of times parents do want their kids to maybe be arrested and go to jail because they think they'll be safer in jail, where they're going to be, surrounded by support staff. Well, a lot of times that's not the case. A lot of times jails don't actually have treatment. That's starting to change, which is good. But inpatient residential, another modality of treatment where a lot of times parents want to know their kids are like off the, like in a safe place. The research actually shows that if you put somebody in inpatient residential treatment and you don't give them medications, their risk of overdosing and dying after that treatment is higher than had they dropped out of treatment. So they're actually better off dropping out of treatment than completing a 28-day residential. This is just for opioid use disorder, and that's just when medication does not accompany the treatment. But I think the best way to treat patients in all different healthcare settings is with an array of different synergistic treatments. And so we see a lot of that. We're seeing more and more of that, where you combine the medication with the behavioral supports and therapies and then even case management stuff, which I'll talk a little bit about in a minute. But that type of ecosystem is what leads to the best outcomes. Let's go to the next slide. This is just some we measured. This is our own internal data, actually, from our company. We have over 20,000 patients in treatment right now across 13 states. We do it's called social determinants of health, if you've heard of that term. We do SDOH surveys upon every medical provider visit, so at least once a month on all our patients. So we're able to actually look at trends over time. And just looking at some of these data points, you see unemployment goes from 60% down to 52.5%. That's in the first 30 days, and then goes down to 27.6% at the 1 year mark. And so dramatic, more than cut in half the unemployment rate of patients when they're in treatment with us. Unstable housing improves, income improves. The two on the right, pretty interesting, because we treat their opioid use disorder. We don't focus on treating their depression and anxiety. We typically partner with other agencies that do that. We do some of that in-house, but we do a lot of that in partnership with other agencies. But this is we didn't actually know this until we started collecting this data. At the 30-day mark, look what happens to depression and anxiety just for patients stabilizing in treatment and getting their opioid use disorder dealt with, like dramatically improved. So very, very cool. So lots of positive outcomes around medication-assisted treatment. But I'm going to talk the next couple slides about just the kind of the nature of addiction and how the treatment actually works in the brain. So the next slide is this is showing like a withdrawal timeline, and there's a lot of misconceptions about withdrawals versus cravings. Cravings typically only last like maybe 2 weeks, right? And they're actually not that hard to manage. You can manage them with comfort medications. There's a lot of things you could do to manage craving. Have I been saying cravings this whole time? I meant withdrawals. The withdrawals are in the first 2 weeks. Those are easy to address with comfort meds. The cravings can last years, and I'll go over this on the next slide. But if you look at this, is just it peaks right in the first 72 hours. That's why a lot of times when patients first enter treatment, I mean, those first couple days are very, very important. And even in our treatment setting, that's when our patients are the most vulnerable, because if somebody's has a high tolerance for opioids because they're using fentanyl or heroin, when they come into treatment with us, we can't start them on a high dose because we don't know. We're just taking their word for it, their prior use. There's not a test to test like someone's tolerance level. And so we have to start them off at a low dose and slowly titrate them up to a stabilizing dose. That could be hard to do in those first couple days. And so it's imperative that, like, in those first couple days when somebody comes in treatment with us, we're wrapping around support. A lot of times patients are at risk of dropping out of treatments, returning to use, struggling during those first 72 hours. And so we put a lot of emphasis on just those first 72 hours. But then even after that 2 week mark, let's go to the next slide. The recovery, the actual physiological recovery in people's brain is a very long-term process. People think you could just treat somebody in 30 days. Let's put them in a 28-day residential, treat them for 30 days, and bam, their addiction's gone. Well, brain scan technology tells us that's actually not what happens. So the brain on the left is a healthy brain, and the red areas is actually endorphin activity in someone's brain. And you see after 1 month of abstinence, after heavy use, I think this was after 2 years of use, roughly 2 years of use, 1 month abstinent, you see their brain activity is very slowly returning. Even at the 14-month mark, it's not where it was originally. So this is called, I think the technical term is endogenous opioid deficiency, where people's brains actually stop producing things like dopamine and endorphins because they have an exogenous supply. So their brains stop producing it. And it takes years. It depends on the person. It's different for different people, but it could take years for people's brain activity to return to normal. And that's really where the medication comes in. And so go to the next slide, and now the next slide, and then we'll go back to this. I should have done it differently. So the way these medications work in people's brains are the on the bottom, those are actually it's called the mu receptors, the opioid receptors in people's brains, which are actually the same receptors that cause dopamine release in your brain. What the medications do is they actually fill those receptors. So it helps with the cravings and the withdrawals. Now, there's 3 medications that are used. Methadone is called the full agonist, meaning it fully covers that receptor. It fully fills it, I should say. Buprenorphine, it's a partial agonist, so it's not as strong as methadone. Partially fills it, and then naltrexone actually just blocks the receptor. It's called an antagonist. So what these medications actually do in someone's brain is they stabilize the brain chemistry. So they're not going through the withdrawals and the cravings that they were going through because their brain's not deficient now. Well, it's still deficient, but you have an exogenous chemical basically stabilizing the person's brain chemistry. So once you stabilize that brain chemistry, then people can deal with the psychosocial interventions or can respond to the psychosocial interventions that we provide in our clinic. So we do a lot of counseling and different types of therapy, and like you mentioned, Debra, IOP and different types of group and teaching people coping skills. For instance, those a lot of times when people are first into treatment and they're first in those couple weeks dealing with the withdrawals, they're not in a place to deal with the trauma from their childhood, for instance. So we get them stabilized on the medication so that we could then deal with those other issues. And so that's how these medications actually work in the brain. And let's see. Now let's go to the next slide. Actually, the next one. I'm sorry.
All right.
The next one. There's this misconception in our society that MAT is just trading one drug for another. And the reason I explained kind of the physiology behind the medications themselves is because people say things like, well, you're just replacing one drug for another. Well, actually, methadone, for instance, has more chemical similarities to your brain's own endorphins than it does to other opiates. So you're actually replacing the missing chemicals in people's brains with a exogenous chemical. And so it's not replacing one drug for another any more than, I have a slide on diabetes, like a type 2 diabetic getting insulin to replace the insulin the body's not replacing. It's more akin to that. And so and in addition to that, methadone and buprenorphine, they're FDA-approved medications for the treatment of addiction. They're done in a very controlled setting with a specialist, with an addictionologist, and we know the potency, the strength of the medication. With illicit opioids, you don't know what's in it. A lot of drugs are being cut with fentanyl these days. You don't know the strength, you don't know the potency. It's very dangerous trying to stave off your withdrawals outside of a treatment setting on your own with an illicit substance. And believe it or not, the majority of patients that come into treatment with us, by the time they come into treatment with us, they're just trying to stave off their withdrawals. They're past the point of getting high because they built up so much of a tolerance that they're actually just trying to stop the withdrawals. And so that's what the medications do when they come into treatment with us. And then again, monitored by a medical provider. And then something I forgot to mention just about the way methadone and buprenorphine, the way those drugs work in the brain, methadone in particular, it's a very, very slow acting. It's got a long half-life, so it's slow acting in the brain. So it doesn't rush someone's rush someone's receptors like fentanyl or heroin does. Heroin might flood the receptors with endorphins, which gives you a high. Methadone actually doesn't, because it's a slow onset. It's got a long half-life. So what it does is, instead of giving you that spike, which then gives you the euphoria and the high, it actually helps with the withdrawals and the cravings without giving you that high. That's exactly why methadone was first even identified as a treatment for addiction, because it's the opioid that can not give you a high but stave off the withdrawal. So that right mix in people's brains. And so that's kind of the chemistry and physiology behind the medications. But now let's go to that definition of addiction slide, which is 10, because this is something that I think is also confusing to a lot of people. The definition of addiction is, first of all, it's defined as a chronic relapsing brain disease, and it's characterized by compulsive drug use despite harmful consequences. Okay, that's a really, really important point. So you hear people offhandedly say, I'm addicted to working out, or I'm addicted to coffee, or whatever. That's actually not the right use of the word addiction, because addiction is using something in spite of negative consequences. Now, like if you're breaking your arm every time you go to the gym, I guess you could call it an addiction. But in general, you hear things like, that baby was born addicted. Well, that's actually not true, because the definition of addiction is using in spite of harmful consequences, knowing something's harming you, and then a compulsive need to keep using it. So even the idea that people get addicted to methadone or buprenorphine, they can, especially outside of a treatment setting, but in a treatment setting, that's actually not the right term. We wouldn't say diabetics addicted to their insulin, or somebody with glasses is addicted to wearing glasses so they can read, right? Well, they might say they're dependent on them, they can't drive without the glasses, but that terminology is really important as we talk about using a medication to treat an addiction. And the next slide is just kind of reinforcing this point. There you go. I'm making it hard on you, Debra, so thanks for keeping up. But just hitting this point home, we don't treat addiction in our society like we treat other types of diseases, right? We don't say somebody that has heart disease deserves it because they shouldn't have eaten as much red meat as they ate, or somebody with cancer deserves it because they should have spent so much time in the sun, right? But we look at addiction that way, and even more so, we look at treatment for addiction a lot of times that way. We do things like, in the treatment community, you'll see people get kicked out of treatment programs for continued use, right? You'll say, well, this person, maybe they stopped using their heroin after 6 months in treatment, but they're still using methamphetamine, so they get kicked out of treatment. It's like, well, wait a minute, they stopped using heroin. Like that's called harm reduction. We use the term harm reduction, which is any positive change, which is if somebody is using heroin 4 times a day and 3 months down the road they're using heroin 3 times a day, that's movement in the right direction, right? But in things like diabetes treatment, right, there's medication, but there's also behavioral health changes that are prescribed, and that's important. The combination of the two are important. But if somebody in treatment with type 2 diabetes, let's say, comes to their doctor and says, hey, I ate terrible yesterday, I had donuts all day, like the doctor's not going to kick him out of treatment, right? The doctor's going to say, okay, let's talk about your dose of insulin. Let's talk about any modifications that are needed, any behavioral health, interventions that might be able to support you. Like, how can we really improve your situation? And we don't see that, unfortunately, in addiction treatment. And that's something we're trying to change. We're dramatically trying to change. Next slide here. This is another item that comes up a lot, and just for everybody's sake, like I like to focus on these misconceptions. I call them misconceptions that our society has about addiction treatment, especially about MAT and things like methadone. But people ask all the time, like, what's the ideal length of treatment? That's a very hard question to answer, because the best amount of treatment is, I like to say, it's not one more day longer than is needed. Not one day longer than what is needed, but you got to offer what's needed. And the research tells us that anything less than 1 year of treatment with medication is typically not effective. Like, it's got to be a minimum of 1 year. The research also tells us it's closer to probably 3 years. That's the ideal amount of time in treatment. There's a lot of patients that are on treatment for the rest of their lives. 10 to 15% of OUD patients, this is from a national study, are on it for more than 5 years. Another study out of Australia, a longitudinal study that studied patients over 15 years. So it's a really impactful study. It showed that at the end of the 15-year study, about 50% of the people that had an opioid use disorder had actually died from their addiction. And the only difference between those that had died and those that were alive were whether or not they were on methadone. But even those that were on methadone, only 25% became completely abstinent, never returned to use again. 25% stayed on medication long-term for at least the 15 years of the study, and 50% were in and out of treatment. And so it is a long-term course of treatment. It's individualized for each person. We tend to think as an agency, and I'm not sure, I don't think the research corroborates this yet, but if you do a better job on teaching people coping skills and the behavioral health wraparound therapies and stuff like that, help people deal with their social determinant of health needs, like you're going to see better long-term outcomes. So combining that with the medication, we believe is going to lead to the actual best long-term outcomes, but it's different for every patient. Okay, 2 more slides here, and then I'm going to turn it back to Debra. Why do people, so in spite of everything I just talked about, why don't people seek treatment? The research says 96.8% of people don't seek treatment or acknowledge a need for treatment. That statistic actually comes out every year. It's out of the national, it's called NSDUH survey. It's a household survey on drug use. And this year, I think it was 94.7%. 94.7% of people with a substance use disorder don't seek out treatment or don't acknowledge a need for treatment. So if you're, I mean, everybody on this call probably has an experience where you had a friend or a family member, or yourself, you went through an addiction yourself, and you've thought, undoubtedly, Debra, I'm sure you've thought this too, what could I had said or done to get my so-and-so to acknowledge a need for treatment or to seek it out? You know, that question that drives our company strategy constantly, thinking about that. What is it that's stopping people from getting treatment, from seeking treatment and getting it? And a couple things we've landed on is, one is stigma. Stigma, there's a lot of research that stigma is the #1 reason people don't seek treatment. Okay, and that could be internal stigma. People don't want to have come to terms with the fact that they have an addiction, and they might say, you know, my doctor's prescribing my opioids, and I can control it, or I can control my use of illicit drugs, and I don't need help. So a lot of times that to me is stigma. They don't want to come to terms with the fact that they might need help when they do. External stigma from their friends or family members. They don't want or employees. They don't know. They don't want their employer to know that they're getting treatment, like that external stigma. And then the stigma against treatment itself, stigma against things like medication-assisted treatment and methadone and buprenorphine, right? So stigma is the primary reason people don't seek treatment. What can we do about that? Well, breaking down the stigma is one thing. We spend a lot of time just trying to educate communities and stuff to break down that stigma, but also compassionate care. Like there's a ton of research that treating people from a place of compassion, treating even empathy as a factor in our staff and how they interact with our patients. The research says that is going to lead to better care for people, and that's also going to break down some of the mental barriers in people's minds that are stopping them from seeking treatment, because a lot of times people are scared of treatment. Like if you think about it, people that use drugs in general or have a substance use disorder, that drug has been their coping mechanism for sometimes like their entire adult life. A lot of times it goes back to the age of 12 or something. And so during those teenage years, a lot of people that develop an addiction during the teenage years, instead of learning to cope during high school, like people not using drugs are forced to do, a lot of times those drugs become the coping mechanism for people. So when people are coming to treatment with us, they're a lot of times saying, this coping mechanism that I've relied on for the last 10 or 20 years, I'm willing to walk away from it. And that's incredibly difficult to do. And when people make that decision, we call it the moment of hope, they're doing that in a place of extreme vulnerability and fear, right? Because they're giving up that coping mechanism. So it is absolutely imperative that we, I would say as a society, but definitely as a treatment provider, treat those people from a place of compassion. Let them know that they're welcome. And in our clinics, when they walk in the clinic, we want to make sure that they see that we're there because we care about them. And that's ultimately going to lead to better success rates in their care. But it's also going to lead to more people seeking out treatments that are possibly afraid to seek out treatment because of the sometimes punitive nature of treatment. And then this next slide, just kind of segueing back to you, Deb, because this is just a breakdown of payer of the payer mix or representation for people with opioid use disorder. So you can see here about 38% of people with an opioid use disorder have Medicaid. This was 2016, 2017. I'm not sure what's changed since then, but about 36% have private insurance. Now, I can tell you in our programs, and I'm sure this goes for all programs across the country, we're about 65, 75% Medicaid funded. Only about 10% of our patients have private insurance. So for some reason, I haven't been able to figure this out. I don't think anybody's figured this out. For some reason, people with private insurance don't get treatment. And that is, and definitely don't get medication-assisted treatment. That's a nut we have to figure out how to crack. I think a lot of times the employers, and that's what I'm so excited about this series. The employers have an ability to make an impact there on what they're covering, and in their choosing of health plans. So Debra, I'll turn it back to you.
Thank you so much, Nick. That was really educational, even for somebody like me who's been in the depths of it for a bit. And you provided the perfect segue, because I'm thinking here, we all represent employers, and I'm going to be asking you to consider some things in these next few slides about how you as an employer can help someone if they come forward to you wanting help. If they take that moment of bravery and that moment of vulnerability to convey that they need help, how can their employer best help them? And employers of choice will take that position. They're there to help, much like they would someone with cancer or diabetes, as Nick explained. So I hope that we've convinced you that purposefully addressing OUD in your organization has a lot of benefits. And I would say sometimes you need a little help, maybe advocating for action. And one way to do that is to calculate the cost of doing nothing, right? So on our OUD website, and I think Paige, you'll pop that in the chat there so everybody has a chance to visit that after our webinar here. But you'll find tools like this one where you can calculate that figure, the cost to a business like yours, a business in Arizona. You can plug in your number of employees and what your industry is, and determine what the cost of OUD is in your company. So look at this. For this company in Arizona, in manufacturing, 500 employees, lost time cost this company almost $127,000 a year. Job turnover and retraining, if you're just firing people under a zero tolerance policy, $183,000. The healthcare coverage of it, $135,000. So you can see this total cost to the company, getting up toward $500,000 right there, right? So definitely worth it, not only from a humanitarian standpoint, but also there are cost benefits to having positive policies and reducing stigma within your company. So you can find this calculator on the website, on our website, and find out your own number. All right. So when you look at that same company, 500 people in Arizona manufacturing, not only do they have employees who suffer from opioid use disorder, but those employees have dependents and family members. Those dependents might be covered under the employer's insurance, right? But at the very least, much like my story, I was incredibly impacted by my son's journey. So I wasn't an employee, but I had dependents and family, and could have used some support during that time from my organization. So I also thought, as Nick was talking about medically assisted treatment, maybe you can even talk your company into covering the cost of medically assisted treatment, right? And make sure that that's part of your benefits package. So I think the benefits are really clear. Employers who have strong workplace policies, not a zero tolerance policy, who participate in employee education, who have health benefits programs related to OUD, have well-trained managers who create safe and healthy environments. These companies are going to do very well. They're going to increase their ease of recruitment and increase employee loyalty and morale. They'll become an employer of choice. They'll reduce the risks of errors and injuries, which are also a major cost to companies. And with the opioids often prescribed for these, can become a precursor to it as well. Fewer HR complaints and requests for issue resolutions, and lower workman's compensate costs. So all good reasons to take a look and see how you might improve your own program. Really, just by talking about opioid use disorder and reduces the associated stigma, providing support rather than punishment to those who want to get treatment, you can actually improve your organization in each of those areas that we just looked at. A lot of people say, where in the world do I start? Because it isn't something they've been exposed to, thank goodness, right? But now you want to be prepared within your company. Well, as I mentioned, a good start is really to abandon that outdated, punitive zero tolerance policy. It doesn't work for one reason, and then there are lots of legal drugs, including opioids prescribed by a doctor, that you just really can't fire somebody for it under a zero tolerance policy. So beginning these open conversations that address OUD like any other chronic disease like cancer or diabetes, and having workplace policies that encourage employees to be honest about their disease and to pursue medically assisted treatment, the gold standard of treatment for OUD, and then help support their long-term recovery. So this is from our website here. You can go there at any time. It's completely free, and we've assembled evidence-based resources. The Health Impact team at Valley Leadership brought together expert leaders from HR, policy, healthcare, communications, and lots of other areas, public and private, to develop this free toolkit for Arizona businesses to help them move toward this more positive culture that regarding OUD. So the toolkit has over 100 resources that are vetted from respected sources to help businesses as they work through this transition. Now, research tells us that simply talking about elevating the conversation about OUD helps to reduce the associated stigma. And reducing stigma is that essential first step to giving employees a level of comfort to come forward and ask for help for themselves or a family member. So when you go to the website, you can get this it's kind of an intake form or a toolkit checklist. You put a little bit of information in about your organization. Oops, sorry, that was clicked accidentally there. And it will give you some places to start. What you can do is you talk to your leadership about instituting some new programs or policies, how to review and maybe edit your policy around drug use. We're not advocating that anyone allows someone to linger in behaviors resulting from addiction on the job, but if they come forward and want to get help, you should be prepared to help them, right? So creating a clear policy around it. How to communicate it to your employees during annual benefits enrollment is a great way to do that. Making sure your EAP has addiction experts on it that can provide counseling or resources for recovery, treatment and recovery. Lots of HR helpful information there. Also, there's templates for how to communicate it, what to look at in your benefits program, and then what employees might need and how you can help support them there. So oudbiztoolkit.org, and just answer a few first questions and it will shoot you this customized checklist. And when you enter your questions, it will return to you, it'll curate the resources so that you have exactly what you need to get started, whether you're a small company or large company, whether you're security sensitive or safety sensitive industry or whatever it might be. So that I think gets us to our questions and answers, and I think we're just on time for that. So well done, Nick and Debra. Paige, do we have any questions that have come up?
We are waiting for questions right now, but in the meantime, Nick, I know you mentioned that you had some questions for Debra just from her story. So I know her story is something that a lot of people may relate to. So we wanted to jump in with that.
Yeah, it's almost more of a sidebar conversation, but Deb, if you don't mind, like this is something I think about all the time, because so I lost a sister to heroin overdose when I was 21 and she was 20, and went through a lot of what your family presumably went through, and And I remember the therapist at the time was telling my parents, you need to cut her off. Like she's got to hit rock bottom in order to, like, she's got to figure that out on her own. And I've thought about that a lot over the years because, you know, I kind of hate that. In today's day and age, hitting rock bottom a lot of times means dying. I mean, with fentanyl especially. I mean, the research says that people tend to overdose about 3 times before they die. That's old research. With fentanyl, I'm sure it's actually different. But this concept that, like, you gotta let people hit rock bottom, is that did that work for you at all, or what did or maybe it was just your son that made the decision on his own? But I guess to like a parent out there, what advice would you give them to encourage their kid to get treatment?
So my advice would be, don't do what I did. Because, you know, from a place of not knowing, not having experiences for the first time with my family, I wanted to be a hard ass, right? It's like, he's made his bed, now he's gonna lie in it. You go, if you want to go get treatment, go get treatment. My husband has a much more compassionate heart. And like I said, you know, I admitted we argued a lot about how to pursue this. But I did not want my marriage to be another victim of this issue. So
Yeah.
I gave in a lot, and I'm really, really glad I did, because my husband said, and this is very wise, if he wants to get help, we should help him. And so every time he, you know, and he probably had 3 or 4 relapses along the way, I'd say. And I should have mentioned this before because you guys are probably wondering, but he's doing great now. He's been clean and living in recovery for 4.5 years, and he is employed, and he's just a wonderful, wonderful young man. And I admire him for what he's been through and how he has found the strength within himself to keep going back for treatment and to practice his recovery and be resilient. So that's all good news. But I would say rock bottom. Everybody will hit their. It's different for everybody. What will happen to encourage them to seek treatment, and it rarely comes from outside, right? I mean, you as a parent, I begged, cried, pleaded, told him not to come over anymore. I mean, it's just, you know, he gave up a lot of things in favor of his drug, and he had to be ready. He had to not be able to live with what he was doing and what he had become for himself. But when he wanted treatment, we helped him find it. We helped pay for it, whatever insurance wouldn't pay, and you know, welcomed him back to our family. Now, we didn't, you know, give him a bunch of money. We were, you know, didn't just hand things over, right? We were smart about it. But I feel like if someone wants to get help and you have the ability to help them as you would with it as an employer, you should do it.
Yeah. Awesome. Thanks for that.
Thank you both for sharing your stories. Audience, if you do have any questions, please feel free to send those over. Otherwise, Nick, Deborah, if you had anything else that you wanted to share at this moment.
Well, it's very hard to know what to do when you're in that situation, whether you're a family member or you're an employer. Given the prevalence these days, I would say be as ready as you can. Get naloxone and know how to use it so you can reverse an overdose. I think that's key, right? Especially if you know you have people around you who might be misusing opioids. As an employer, like that should be part of your first aid kit, I think, you know. And then if you're in HR and somebody, you know, you're starting to have these conversations, be aware of what the resources are. We're adding some of those to our website now, but there is a great resource with the state called the OAR line, OAR line. You can look that up online and find both the web address as well as the phone number, and it's a directory of resources, and you can look for things there. And as Nick has mentioned, medically assisted treatment is the gold standard for treatment and the most effective long term. So I would definitely learn more about that and understand how to refer people for treatment.
Awesome. Well, thank you both, and thank you to the attendees who have joined us today. We will be sharing out the recordings for all of the sessions, so please feel free to share this with your leadership, other people in the community who may benefit from this information. It is so important, as you've seen, that we continue to elevate this conversation and make sure that people are aware of the crisis. So thank you again, Debra and Nick, and I hope everyone has a great rest of your afternoon.
Thanks for having us.